ladies and gentlemen. Welcome back to another fabulous episode of the Healthcare Trailblazers Podcast. Excited to be sitting here today with the wonderful Dan Blumenthal. Dan is has a ton of really interesting experience, started a company, and is now the president of Novocardi. A lot going on. And so, Dan, thank you so much for spending time with us today.
Oh, it's great to be here, Mendel. Thank you for having me.
So let's quickly, where'd you grow up and how'd you get into healthcare?
So I grew up outside of Boston and have two parents who are both physicians, and went to college not thinking that I was going to be a doctor. And then in my senior year of college, decided that I started to get interested in medicine and really made the decision to become a doctor after graduating from college. And so went to medical school and did an MBA as well, and then trained in internal medicine and cardiology at the Mass General Hospital, which is also in Boston, where I went to medical school. And then shortly after finishing cardiology fellowship, I thought I was going to be a health services researcher. I applied for grant funding and then got wooed into going into industry and worked for a company called Devoted Health, which is a Medicare Advantage health plan founded by the Park brothers, Todd and Ed Park, who also founded Athena Health. And so I spent 2.5 years there as the associate chief medical officer and the medical director for the health plan, and then left Devoted to found my own company called Novocardi, which was really dedicated to helping cardiologists, community-based cardiologists, to make this transition from fee-for-service oriented reimbursement models towards incrementally towards value-based care or risk-based contracting reimbursement models. Because in this country, we are moving very steadily, but also relatively quickly towards reimbursement models where physicians are being compensated for taking on financial accountability for quality of care that they're delivering and patients' health outcomes. Yep. And cardiologists are, I would say, have not traditionally been the individuals who have been at the center of that value-based care movement. But I think it's very important that we engage specialists generally and cardiologists in particular in that shift to value-based care, because specialists in this country deliver over 80% of all of the care that's being delivered. And cardiologists are very much at the top of that list in terms of how much care they're delivering and how much of the total healthcare dollar is being spent on cardiovascular care, because patients have a lot of cardiovascular illness.
Yeah.
So,
no easy feat. Moving from fee for service to value based care is quite complex, quite complicated. And where you're a specialist, it's really hyper specific. And so, what are some of the key differences that you find between trying to do that transition as a cardiologist versus just a PCP?
Yeah, how much time do you have? So the thinking, I think they're and I probably won't do this justice in the time that we have, but the thinking behind having primary care physicians take on risk has been that those physicians are generalists. They are, they know a fair amount or at least a little bit about everything in medicine and can really manage the care of a patient. And so they can make decisions about which specialist to use. They can make decisions about what types of testing are needed or not needed. And they can do so relatively impartially because they're not actually delivering much of that care at all by themselves. They're relying on other members of the care team to do so. And I think there's also, a general belief that the primary care physician can be the one to develop that longitudinal relationship with a patient and manage them through 10, 20, 30, sometimes 40 years of life and the kind of ups and downs that develop over the course of one's life. Cardiologists are used to, managing very complex illness and thinking about how they use a number of different tools that we have at our disposal to diagnose that illness, to track it to make sure that it's not progressing or that we understand whether or not it's progressing, to manage patients in the hospital, right? And to do pretty complex procedures. So there are lots of really key differences that make the care model very different. I think what I think really puts cardiologists in a great position to be the drivers of delivering higher value care for their patients are a few things. Number one, there are a subset of patients who have a really complex cardiovascular illness where cardiologists effectively become the primary care doctor for those patients. It's not unlike the kidney care model where, we've seen in this country, Medicare has recognized that people with end-stage renal disease have specialist needs that put the nephrologist at the kind of the tip of the spear in terms of managing the patient. Yes. So there are patients who fall into that bucket and have cardiovascular illness. In addition, I think even for people who don't have illness which is that complex, there are a lot of things that cardiologists, I think, would do differently if they were managing a pool of dollars for their patients. They would think differently about, for example, how quickly they see patients after a hospitalization to try to prevent them from going back into the hospital. They might think differently about how rapidly they try to up-titrate certain medicines that we have every intention of up-titrating, but for which life sometimes gets in the way. And if our guidelines, for example, suggest that they be up-titrated every week to 2 weeks via an in-person visit, it's very unrealistic to expect a cardiologist to be able to see a patient that frequently.
Yeah.
Unless there's some kind of additional care model elements put in place to really ensure that that's happening in a high fidelity way. And that additional care model element requires some additional money often. Yeah. Right? Yeah. Whether, you're paying for an advanced practice provider or a nurse to help manage some of those nuances.
Yeah.
And those two examples are just, or three are just among the many reasons why cardiologists, I think, would behave differently. And if the financial incentives that they face are aligned with really delivering high value evidence-based medicine.
Yeah. And I mean, also, and mind my ignorance if this is totally off, but to my understanding, that by far the highest cost diagnosis in it is heart disease. Yeah. And so that would be a great place to start tackling.
Mm-hmm. For sure. Right. And I think, yeah. So, I mean, we spend $320 billion a year on cardiovascular care in this country. It's that amount of money can be measured as a percentage of GDP, right? It's 2 to 3% of GDP. Mm-hmm. It's cardiovascular illness is the single most expensive set of illnesses, and the prevalence of cardiovascular illnesses are going to increase dramatically as our parents' generation continues to age, and the costs of managing those illnesses is predicted to more than double over the next 10 to 12 years.
Yeah. So there was one thing you could do the same way, heart disease is, if we could knock that out of the country, then that would make a big difference. So within that work itself, what would be kind of like this first step to tackling the lowest hanging fruit? What would be the one action that a cardiologist or a cardiology practice can put into place that would really start driving some of those numbers down to the point that if they did have full risk on their patient panel, that would just be the obvious first step?
Yeah. Well, I think that evidence-based management, very, very close evidence-based frequent touch management of heart failure is probably the single most important opportunity that we face or that we have in the field of cardiology to improve outcomes and reduce costs. There are tons of others, but if we're talking about a single illness with a care model solution, that's it.
So
Um,
better
there-
care
there-
coordination, more touch points, and remote patient monitoring. Just put some of those things into play. It's not that hard.
yeah, that's right. And with guideline directed medical therapy, the use of which we know is not being used at the levels that it should be in this country, and there are a number of reasons why that is: cost, access to the right clinicians, frequency of visits, among the many things that are hampering our efforts to get our patients on the right medicines for managing their illness. But more frequent touch points, right? And better education about
Yeah.
heart failure and what it is and what the symptoms are. And this is not rocket science, but it requires a diligent kind of thorough, consistent approach to delivery of the care that we know works.
Yeah.
And there are lots of others. I mean, but I think in my mind that's at the top of the list.
Yeah. And so I'm sure you weren't always operating in value-based care. What were kind of some of those experiences that inspired your interest or realization that value-based care is a critical path?
Yeah. So great question. So I was at Devoted Health. I was a medical director there, and it was an incredible experience. And I learned a ton, had great colleagues. One of the things that I kind of realized was Devoted had launched in Florida, and I was learning a lot about primary care physicians and how PCPs interact with health plans and work to share risk and manage risk with health plans. And also recognize that they had a complicated relationship with their specialist partners, in particular with cardiologists, and that there was a lot of friction at the interface between the primary care doctors and the cardiologists that they were working with, often disagreements over whether tests were indicated, very different views about motives underlying decisions, meaning, why is this test being ordered, or why is this primary care doctor telling me that my patient doesn't need this test? Who trained in cardiology? I did. They didn't train in cardiology, and in my mind, that was purely a function of, or not purely, to a great extent, a function of the differing financial incentives that those two groups of clinicians face, and that addressing that difference in financial incentives could really help smooth out and improve the coordination of care between cardiologists and primary care physicians, and also help to help to incent the delivery of evidence-based medicine, I think, more broadly.
Yeah. It's so interesting. I always think about this, like, when did this country, like, when did we move into the space where you mentioned earlier, like, one of the biggest issues is patient education, care coordination, right? And it's like just basic information on do this, don't do that, eat this, stay away from that. This is going to be bad for you. This is going to be good for you. Like my good friend, Dr. John White, he's like, eat fish, like, it's pretty simple, like, do that.
You should eat lots of fish. Yes.
Yeah. And so, and so even if we're moving over to value-based care, the first thing we would put in is kind of, having somebody touch more, like you said, more touch points with touch base with the patient, make sure that they're understanding these things, answer their questions. When did the onus of your healthcare move to your doctor? That's what I'm curious about. Because at the end of the day, if we really want to be successful with value-based care, we're not going to be like, we can get paid this way, that way, or the other way. But until we actually figure out how to get the patient in the conversation in an emotionally equitable way to the doctor, you're not going to really be able to change behaviors. Mm-hmm. And instead of thinking about the current situation, it's like, what was this like 100 years ago or 200 years ago when people just lived their lives?
Yeah.
And like, and the onus for their own health was on them. Like, it seems like such a backwards, it seems like normal because we're used to it, but it's really such a backwards dynamic. Why is it your problem to make sure that you call me, to make sure that I don't eat a bucket of sugar every day? Like,
Yeah.
why?
It's a great question. Aside from, so first, I think it is not just purely our responsibility, right? I think it is ultimately the responsibility of individuals to help manage their own healthcare, right? But I think we have a great deal of evidence which has proven that patients' ability to manage their own illness is a function of our ability to meet them where they are and to understand the factors that are preventing them from managing their own health and to try to address those factors. And some of those issues are not purely like, those are not purely on. We're not as healthcare professionals solely responsible for that, right? Patients need to take ownership over that and onus to do it. It's not solely our responsibility, but I think there is a fair amount of evidence that indicates that once people understand what it is that they're dealing with from an illness standpoint, that they're much more likely to actually do the right things. And so now, the degree to which we should be financially accountable for that, right, I think we could certainly argue about. And 100 years ago, you're totally right? Like, if you think you need to see a doctor and you have access to a doctor and you can schedule an appointment, you go see one. And if you don't, then you go to an emergency room, or if there's a hospital in your region. But I think the evidence would also suggest that kind of public health campaigns and the work that we've put into driving reductions in smoking and improving rates of activity and improving rates of early identification and treatment of hypertension, and other cardiometabolic precursors of illness, that those have actually led to substantial overall improvements in public health.
Yeah.
So there have been really great success stories, I think, for us as a society, right? Despite the fact that maybe we are now asking more of our health plans and providers in terms of the accountability that they hold for those health outcomes.
Yeah.
And I guess the way that I might also think about this is, if you go and look at you want to buy a television, right? You shouldn't pay the same amount for a television which gives you a black and white picture, turns on, has 12 channels, as you might for a sleek flat screen TV, which gives you 100 channels and lasts 10 years. Ultimately, we want to reward people for generating a better product. And so I think about how we can encourage people to compete on the value that they generate for patients rather than just compete on service delivery. And that's really, really complex in healthcare, right? Because you're not in control of the product sometimes.
Right. So the government has been pretty clear, CMS has been pretty clear that they want the country moving in this direction, of course, setting a deadline of 2030 for everybody to be in some sort of value-based care arrangement. Do you think that's practical?
I think that is. I think that it is practical. If we look at the kind of the Medicare population today, a little over 50% of our Medicare beneficiaries are in Medicare Advantage, which is privatized Medicare. And those patients are increasingly becoming part of shared risk relationships between physicians on the ground and the health plan. And health plans are continuing to move very quickly to try to share risk for as many of those beneficiaries as they can. So right there, I think we're looking at a majority of the Medicare population effectively being in a managed care shared risk model. Likely,
MA plans are going to fit that they're going to check off
that box. Yeah, that requirement. I think that and Medicare didn't include them in its. I guess it did technically, but the announcement was, really with respect to Medicare fee-for-service beneficiaries, not Medicare Advantage beneficiaries, but I'm thinking broadly about the Medicare population. Amongst the Medicare fee-for-service population, we have I think a majority in ACOs right now, and
really?
Yeah, I believe so. Yeah, so or about half. So we're really talking about somewhere between 18, I think 15 and 25 million Medicare beneficiaries now who need to be kind of shifted into Medicare fee-for-service accountable care organizations or accountable relationships.
Yeah.
And I think that we'll get close. I don't know if we'll get 100, if we were to turn over every last stone, could we be 100% confident that we'll get there? I don't know. It come 2030, but I think we're going to get close.
They'll turn on the punishment. They'll bring out the stick, and then the rest will fall.
Yeah. Well, I guess I don't know who gets punished is the question, because there's no one to really punish if we don't get there, other than.
Well, they can start dinging reimbursements if you're not. The same way you'll have to have an active EHR these days to really be qualified for anything. They can just say, okay, if you're not here, then you don't get paid.
Yeah, I guess true. True, though the ACOs are typically. Yep, I see what you're saying. The ACOs are typically somewhat separate and apart from the providers, right? So because the providers are not the ones driving the ACO, they participate in them. Right. I do think there has been a plateauing of Medicare ACO growth and enrollment recently, so I think I do think that Medicare is, and I know Medicare is aware of that and is trying to think through not just how they promote ongoing growth of the accountable care movement, but also how they engage specialists in this work. They're very committed to remaining kind of primary care centric, and I think that may have to change a little bit too for the ACO movement to continue to expand.
Interesting.
But I think that we'll get close.
So do you guys provide, it's kind of consulting services? You hold people's hands and you walk them through the process?
So we're a combination of a few different types of businesses. So, Novocardi emerged with Cardiovascular Associates of America. And we are together a combination of a cardiology practice management platform. So we own cardiology practices in 8 states. We have about now 370 plus cardiologists across 8 states. And we provide...
How many cardiologists?
370 plus.
Nice.
Yeah. With, 200 advanced practice providers and, 750 to 800,000 unique patients served.
Wow.
And we And we provide, at least Novocardi provides, value-based and risk-based contracting enablement services. So we help with care model transformation to help our practices to put in place the right kinds of care model elements needed to be successful in value-based care. And we help with contracting model transformation to put in place the right kinds of contracts with payers and risk-bearing primary care referral partners to help kind of move towards that shared risk model that we were talking about earlier, where cardiologists are sharing risk for their patients with primary care physicians and payers.
Yeah. And so we mentioned earlier, one of the first things you would do is start putting in some better care coordination, more touch points with patients. Is that something that you guys, is that a service that you provide? You help them get things set up in-house? How do we get that done?
Yeah, so we have a care model that we walk through with all of our practices, and we help them to understand what it is we believe that they need to do to make themselves. And there, some of them have already done many of these things, others haven't. So we try to meet them where they are, right, and they're on their path to putting in place a value-based care model. We show them what the benefits will be for patients, right? So we share data with them on, many of the interventions that we're talking about are evidence-based. So we share data with them on either published or, or data from our network on why those care model elements we think will help patients. We help them to understand how the care model transformation aligns with the contracting model transformation. And which has to come first, because there's a bit of a chicken and egg process phenomenon here.
Right.
And then, and we also, we also have a set of elements that we do an evaluation, right, of each practice, because you have to understand where the practice is, as I said, to then provide guidance. So so that's part of the process too. And then we put in place a project plan based on where the practice is, what they're focused on, what they do and don't have, and what we think they need to put in place first, second, third, in order to kind of set themselves up for success.
That's awesome. Wow. So you definitely have your work cut out for you. What are some things you're proud of, and what are some goals for 24?
Yeah. I am very proud, I think, of a few things. I'm very proud of well, first, I'm immensely proud of what what the Novocardi and the CVA USA teams have done over the past 4+ years, and of our our ability to kind of face a continuous set of challenges, both kind of behavioral and kind of payment model related. I'm very proud of the Novocardi division's risk contracting work. We launched our first risk contract with an at-risk primary care group about 6 months ago, and it's going very well. We've not had any heart failure related admissions in the population of patients we're managing. We're meeting all of our contractual metrics. And I'm also very proud of the work that we are doing to build relationships in the practices and to help our practice partners understand why it is so important for them to make certain relatively modest changes to how they manage their groups to set themselves up to be successful in risk arrangements. We've also done a tremendous amount of work to build evidence-based care models that have thus far, we've gathered some data on them to demonstrate that they work, and they do work. So, and I'm very proud of that. In terms of goals for 2024, we are working to get all the vast majority of our practices to adopt all of the care model elements. And that's work that we've launched. It's really hard work. It's
yes.
Yeah.
Yeah.
And I'm very proud of how well the team is doing. I think we also have, contracting goals, right, to expand the number and the size of risk contracts that we put in place for our with and for our practice partners.
Yeah.
And so we've got our work cut out for us this year.
Yeah. Yes, you do. Well, Dan, I wish you tremendous continued success in crushing your goals. And
thank you.
Yeah, where can people find you?
Yeah, so they can go to www.cvausa.com to learn more about CVA USA and Novocardia. They can also go to www.novocardiahealth.com. And then they can find me on LinkedIn and on X. I'm at Blumenthal DM1.
Awesome. Well, Dan, thank you so much for spending time today.
Oh, thank you, Mendel. This was great. Have a wonderful afternoon.